The next topic is about the difference in blood pressure between the right and left hand. Normally, the blood pressure in both hands is not exactly the same, and the blood pressure in one hand, usually the right, may be higher than the left, but this difference is typically no more than 10 millimeters of mercury. Therefore, if the blood pressure difference between the hands is more than 10 millimeters of mercury, we must definitely consider the possibility of an underlying pathology. We want to talk about the anatomy of the arterial system. The left ventricle pumps blood into the aorta. In the aorta, in fact in the aortic arch, we have three major arteries. The first one, located on the right, is the brachiocephalic artery, which ascends and then divides into two main branches. One branch is called the subclavian, which goes to the right arm, and the other branch is called the carotid, which goes up into the neck and then forms the cerebral arteries. The middle branch is the carotid branch. The middle branch is the left carotid branch, and finally, the third branch is the left subclavian branch. So three main branches separate from the aortic arch: the right subclavian, right carotid, and left subclavian. The subclavian arteries go into the arms, the right subclavian goes into the right arm, and the left subclavian goes into the left arm. That's why any narrowing that exists along this path we mentioned can lead to a difference in blood pressure between the left and right arms. So the narrowing can be within the subclavian artery itself. This narrowing can be in the left subclavian, the right subclavian, or even in the aortic arch. So we can say that if there is more than a 10 millimeter mercury difference in blood pressure between the left and right arms, the causes to consider are usually narrowings and stenoses. Now, this narrowing may be due to atherosclerosis, and atherosclerotic plaques may be caused by inflammatory diseases such as Takayasu, or it could be due to narrowings like aortic coarctation. Of course, aortic coarctation usually occurs after the left subclavian artery, but in rare cases it can extend to the aortic arch or involve narrowings that develop in the arch. Here, this leads to a difference of more than 10 millimeters of mercury between the right and left arm blood pressures, or subsequent pathologies such as aortic dissection. Aortic dissection causes a dissection flap to form in the aortic arch. It can potentially block one of the major subclavian arteries, thereby causing the blood pressure in one arm to significantly drop when compared to the other arm. And finally, in approximately 20% of healthy individuals, this anatomical variation occurs as a completely normal and expected physiological occurrence. It is possible for the blood pressure in one arm to be more than 10 millimeters of mercury higher than in the other arm. Is the blood pressure in the upper limbs, meaning the arms, different from that in the lower limbs, meaning the legs, or are they the same? The answer is that their blood pressures are different. Is the blood pressure higher in the arms or in the legs? The blood pressure in the legs, the systolic blood pressure in the legs is higher than in the arms, and the diastolic blood pressure in the legs is lower than in the arms. So why is the systolic blood pressure in the legs higher than in the arms? There are two main reasons. The first reason is gravity, that is, Earth's gravity and the hydrostatic pressures present in our bodies. The second reason is due to elastic fibers and elastin fibers. The farther we move from proximal to distal vessels, the less flexible the vessel walls become. In other words, their compliance decreases because they have fewer elastic fibers. And the more distal the vessels are, the stiffer and more rigid they become. And this causes the vascular compliance that occurs in proximal vessels, which acts like a pressure buffer and prevents blood pressure from rising, to be reduced in the more distal vessels. Therefore, instead of becoming more compliant and allowing the vessel to dilate when blood enters, the vessel remains rigid, blood pressure increases, and as a result, the systolic pressure in the lower limb vessels becomes higher than in the upper limb vessels. However, the difference is less than 20 millimeters of mercury. If the systolic blood pressure in the lower limb vessels is more than 20 millimeters of mercury higher than in the upper limbs, then we must definitely consider a pathology. As we mentioned, the systolic blood pressure in the legs is higher than in the arms, and the diastolic blood pressure in the legs is lower than in the arms. Now, why is the diastolic blood pressure lower? Because as we said, the elastin fibers decrease as we move from proximal to distal. That's why the vessels become more rigid and their vascular compliance decreases. Therefore, since vascular compliance decreases, vascular recoil during diastole also decreases. And it is this decrease in vascular recoil that leads to a drop in diastolic blood pressure. So what are the specific factors that cause the blood pressure in the lower limbs to be more than 20 mmHg higher than in the upper limbs? We said that up to 20 mmHg, the blood pressure in the lower limbs may be higher than in the upper limbs. But if it is 20 mmHg or more, we must definitely consider certain pathologies. One of these pathologies is advanced atherosclerosis. When the vessel wall undergoes severe atherosclerosis and becomes rigid and stiff due to calcification, this causes the same physiological phenomenon to be intensified. That is, during systole, the vessel cannot contract, it cannot expand. For this reason, systolic blood pressure increases, and during diastole, since vascular compliance and vascular recoil cannot occur, diastolic pressure decreases. Therefore, in elderly individuals with progressive atherosclerosis, systolic blood pressure in the legs increases by more than 20 millimeters of mercury compared to the arms. The second reason is aortic insufficiency. As you know, the aortic valve should be closed during diastole. But in people with aortic insufficiency due to valve failure, blood flows back from the aorta and enters the left ventricle. This means that we actually have a diastolic runoff, and in fact a large amount of the pressure and blood in the arterial system is discharged into the left ventricle. That's why diastolic blood pressure drops, and on the other hand, systolic blood pressure increases because some blood enters the left ventricle during diastole through the insufficient aortic valve. And we still have the normal amount of blood flowing from the left atrium to the left ventricle during diastole. And these factors cause a large volume of blood to accumulate in the left ventricle by the end of diastole, and this large volume of blood is pumped into the aorta. This increased volume of blood leads to an increase in stroke volume. When the stroke volume increases, it raises the cardiac output. And as we mentioned in the formula, blood pressure equals cardiac output multiplied by resistance, so cardiac output increases as well. Therefore, in patients with severe aortic insufficiency, systolic blood pressure increases and diastolic blood pressure decreases. That's why patients with severe AI have a wide pulse pressure, because in a normal person, the pulse pressure is 40 millimeters of mercury. But in someone with aortic regurgitation, this difference can even reach up to 100 millimeters of mercury. Due to the specific physiological mechanism that I have thoroughly explained to you, the significant pressure difference between the lower and upper limbs in cases of aortic insufficiency becomes notably more than 20 millimeters of mercury, and this particular phenomenon is clinically known as Hill's sign. So, as we said, if the systolic pressure in the lower limbs is more than 20 millimeters of mercury higher than in the upper limbs, we must definitely consider advanced atherosclerosis or severe aortic regurgitation. In this case, if the difference is more than 20 millimeters of mercury, it is called Hill's sign. So what could cause the opposite to happen? That is, what could cause the blood pressure in the lower limbs or legs to be lower than in the upper limbs? What could cause that? Anything that causes a narrowing in the pathway after the left subclavian artery. Imagine this scenario. As we said, in these groups of patients, any factor that causes a narrowing in the arterial system after the left subclavian artery will lead to a drop in blood pressure in the lower limbs. Now, this narrowing might be due to a coarctation of the aorta, especially right after the left subclavian artery. That is, aortic coarctation might be caused by atherosclerotic plaques within the aorta itself. The plaques might be in the lower limbs, in the iliac vessels, or in the femoral arteries, and all of these ultimately lead to narrowing. So, therefore, if the blood pressure in the legs is lower than the blood pressure in the arms, the cause could be due to various types of stenosis, such as aortic coarctation, peripheral artery disease, and different kinds of narrowing like Takayasu, or it could also be due to aortic dissection. Because aortic dissection can also create a dissection flap in such a way that it disrupts blood flow to the lower limbs, while the upper limbs remain fully intact and their perfusion is maintained. Here, an index is defined called ABI. ABI. ABI stands for ankle-brachial index, which means we measure the blood pressure at the ankle, divided by the brachial blood pressure. So, if under normal conditions, the ankle blood pressure is 130 mmHg, and the brachial or arm blood pressure is 120 mmHg, our ABI will be greater than 1. But in a person with peripheral vascular disease, the opposite happens. In this situation, as we mentioned, the blood pressure in the lower limb drops. For example, the ankle pressure becomes 100 mmHg. The arm pressure remains 120 mmHg. Therefore, the ankle-brachial index becomes less than 1. So whenever we calculate the ABI and it is less than 1, it indicates stenosis or atherosclerosis in the arterial system, and it definitely requires us to perform further diagnostic procedures for the patient. Measuring blood pressure in patients who are hospitalized. Many of the patients whose blood pressure we measure are hospitalized patients lying in bed or individuals who are unable to sit or stand, so we are forced to take their blood pressure while they are lying down. In such cases, it is essential that the level of the blood pressure cuff we use is at the level of their heart. That is, the blood pressure cuff placed on the patient's arm must be exactly at the level of the heart. If we position the patient's arm above the level of the heart, meaning for every inch the hand or arm is raised above heart level, the blood pressure will be measured about 2 millimeters of mercury lower than it actually is. In other words, this results in an underestimation of the blood pressure. So for example, if we position the arm in such a way that it is about 20 centimeters above the level of the heart, the patient's blood pressure may be measured about 20 millimeters of mercury lower than it actually is. If the patient's actual blood pressure is 120 millimeters of mercury, we might measure the systolic blood pressure as 100 millimeters. Or if the arm is positioned lower, say the patient's arm is hanging down and below the level of the heart, the blood pressure will be measured falsely higher. This is due to the effects of gravity and hydrostatic changes that occur, and the same rule applies again. That is, for every inch that the patient's cuff or the sphygmomanometer cuff is below the level of the heart, the blood pressure will be measured falsely higher by 2 millimeters of mercury. So, if the level of the arm and the sphygmomanometer cuff is more than 20 centimeters below the level of the heart, the blood pressure will be measured falsely higher by 20 millimeters of mercury. We know that each inch is equivalent to 2.5 centimeters. This means that if we measure blood pressure in that position, the reading will falsely show a higher blood pressure. If the patient's actual blood pressure is 120 millimeters of mercury, in this situation, the measured blood pressure might even reach 140 millimeters of mercury. Therefore, when measuring blood pressure in patients who are hospitalized and lying in bed, it is essential to ensure that the blood pressure cuff is exactly at the level of the heart. When measuring blood pressure in the lower limbs or legs, it is important to always take the measurement at locations where the arterial pulse can be felt. There are 2 points where we usually feel the arterial pulse. One is the popliteal artery, which is usually located below the knee and exactly on the inner side of the knee joint, where we first feel and detect the pulse. The other is on the inner surface of the medial cartilage of the foot, where we detect the posterior tibial artery and can measure the blood pressure there. So one is on the surface of the foot cartilage, and the other is above the knee, where the popliteal artery is usually located, and we feel the pulse. We fasten the blood pressure cuff. An important point is that here too, the same principles we mentioned for measuring blood pressure on the arm must be followed, namely the 80-40 rule. To measure blood pressure in the inner cartilage area of the foot, we proceed in exactly the same way. In the same way, we fasten the blood pressure cuff, and after securing it, we need to position it so that the tube and the rubber tubing parts are exactly aligned with the artery. We also place the stethoscope so that it is precisely over the pulse of the artery, specifically the posterior tibial, and then we check according to the same steps.